السلام عليكم جميعا. This is Rabab Taha, transplant infection disease. I would like to present today a case about Clostridium difficile in bone marrow transplant. Let us start. Bismillah. So I will start my presentation with anecdote of this patient. He's my patient, Muhammad, who's a fighter. He battled acute myeloid leukemia and he went successfully through chemotherapy, but guess what? Unfortunately, he passed away because of complications secondary to Clostridium difficile infection. So Clostridium difficile infection is one of a growing threat in hospitals, and we should control it. We should study it, especially in the population of allogeneic bone marrow transplantation, which I will delve into the epidemiology. I will highlight the potential consequences of Clostridium difficile infection associated in allogeneic bone marrow transplant. We will explore the challenges in diagnosing Clostridium difficile in this group. And finally, we'll conclude with the treatment options in bone marrow transplant. But I would like to start asking a question. So we're supposed to have a poll everywhere for voting. So I need show hands. I don't know. It's supposed to be here, the barcode and the voting. Anyway, I need to ask you, would you start treatment for Clostridium difficile with the vancomycin or fidaxomicin? Who will go with the fidaxomicin? Fidaxomicin, considering the treatment effectiveness, the cost effectiveness, and the recurrence rate. Fidaxomicin, vancomycin. Okay, so the majority will go with the vancomycin. Now we'll start with, I will go shortly through the mechanism of Clostridium difficile in allogeneic bone marrow transplant. So the microbiome, the intestinal microbiome, plays a great role in transforming the primary bile acid into secondary bile acid, which in turn will suppress the germination of Clostridium difficile infection. So if there is any disruption in the microbiome, it will give the best environment for Clostridium difficile infection to grow and to germinate and to cause disease. So which for hematological malignancy patient or the allogeneic bone marrow transplant are significantly at high risk for Clostridium infection because they have a prolonged antibiotic, they are exposed to prolonged antibiotic, recurrent hospitalization, and the chemotherapy that disrupt the microbiome and the intestinal wall. In bone marrow transplant, they experience 9-fold increase in the risk of Clostridium difficile in comparison with normal population. And the risk is doubled in allogeneic bone marrow transplant in comparison with autologous bone marrow transplant. What about the recurrence? So the recurrence rate in normal population is 1 in 6, but it's increasing to 1 in 3 in allogeneic bone marrow transplant. This is Eric et al. They did an epidemiological study in allogeneic bone marrow transplant, and they highlighted some variables associated with increasing risk of Clostridium difficile infection. The most important thing is graft versus host disease, and CMV itself will increase the risk of Clostridium difficile. Surprisingly, tigacycline and Bactrim has a protective effect in Clostridium difficile. Why it's important? Though there is no studies, but I think we might use Bactrim and tigacycline instead of other antibiotics that increase the risk of Clostridium difficile infection. So as a conclusion for this part, what are the predictors for Clostridium difficile in allogeneic bone marrow transplant? We can say from multiple epidemiological studies in allogeneic bone marrow transplant are antibiotic exposure, the duration of hospitalization, type of hematological malignancy, the chemotherapy, and the graft versus host disease. Now, do you think there is any potential consequences with Clostridium difficile? Will it affect the success of bone marrow transplant? Show hands, yes. Will it affect the bone marrow? No. So some study, there is no conclusive trials, but some studies suggesting that Clostridium difficile will increase the risk of bacteremia, especially with resistant organisms. The other important thing that caught my eye that Clostridium difficile infection will trigger immunity, it might cause increase the risk of graft versus host disease. And there were multiple trials highlighting the risk of graft versus host disease after having Clostridium difficile infection. So probably there is a potential inverse relationship between Clostridium difficile infection and the graft versus host disease. Now, it is really challenging to diagnose Clostridium difficile infection in these populations because we don't have the severity criteria. Those patients probably they won't have fever and they don't have leukocytosis, probably leukopenia. And diarrhea is one of the most common symptoms in those populations. So sometimes it's challenging to diagnose Clostridium difficile infection, and we have to avoid improper treatment even with vancomycin. Okay, so what I want to say that we should never treat Clostridium difficile infection based on the PCR only because PCR means colonization, but PCR has a very high negative predictive value. So if it's negative, probably we can rule out Clostridium difficile infection. Now we'll come to the part of treatment. This is it gets stuck. Can we, please, I need a help. Okay. So this is actually just published in 2024. It is about a treatment of Clostridium difficile infection. They studied metronidazole in comparison with the vancomycin. And it showed that vancomycin is way better than metronidazole. What about the combination therapy? We can see that vancomycin alone is much better than metronidazole alone and is better than the combination therapy. So there is no role for metronidazole in allogenic bone marrow transplant and no role for the combination therapy in allogenic bone marrow transplant. Now, this fidaxomicin versus vancomycin, and I think we should really start thinking about which medication is better. Although there is no randomized controlled trial to highlight fidaxomicin or vancomycin in allogenic bone marrow transplant, but there is a randomized controlled trial in a cancer patient. So this study, it showed that fidaxomicin is equivalent to vancomycin in treating Clostridium difficile in immunocompromised patient. However, fidaxomicin is way better than vancomycin in the recurrence rate. So fidaxomicin associated with less recurrence rate except with the binary toxin 027, which I think we don't have it in Saudi. I don't know anyone. I asked multiple centers. I don't think we have these toxins, but we have to have epidemiological trial to know if we have this toxin. And there is multiple retrospective studies comparing fidaxomicin with vancomycin in allogenic bone marrow transplant. And the conclusion was very contradictory. Some studies suggesting using fidaxomicin as a better option, and some studies it showed that comparable effect between vancomycin and fidaxomicin. So how we can answer the question that I asked you? We have to go to the next step, which is the microbiome, which is very important in allogenic bone marrow transplant, and I will show you why. This is a very interesting study was done in 4 centers of allogenic bone marrow transplant, published in New England Journal on 1,362 patients. They took the stool from those patients before the transplant, 7 days before the transplant, and then 0, 7, 21 days after the transplant. They studied the gene consequences or the metagenomic, and they found that very interesting finding that the lower the diversity of the microbiome, the higher the dominance of Enterococcus infection, which now, since 2015 until now, is showing that Clostridium, that vancomycin is increasing the risk of Enterococcus infection, bacteremia, and colonization. So the conclusion of this study, the higher the diversity of the microbiome, the lower the risk for the graft versus host disease. This is another study done in vivo in mice, and it showed, it's very interesting also, it showed that the right upper graph is showing the normal flora before any antibiotics and without Clostridium difficile infection. And the lower graph is showing the difference between in the microbiota before and after giving fidaxomicin and vancomycin. Just see the colors of the vancomycin. It's completely changing the microbiome in comparison with fidaxomicin, which almost similar to the same flora. And this is also very interesting, was presented recently in the ICMET, and it was done from like a group of scientists, microbiologists. They did it in vitro. They incubated Enterococcus with Clostridium difficile, and the study showed that it is formulating like a biofilm, which can explain the recurrence rate, the higher recurrence rate with the vancomycin. And the lower picture is showing that after giving the mice the treatment with fidaxomicin and with vancomycin, the blue one is with fidaxomicin after treatment. It's showing complete resolution of the Clostridium difficile. However, after vancomycin, it's showing remnant disease, like probably it is a biofilm causing the recurrence of infection. And now, and as I said, there is multiple studies showing the abundance of Enterococcus infection in patients who are on vancomycin. However, this is always the question. We don't have fidaxomicin, and fidaxomicin is extremely expensive. But do you think it is valid to have fidaxomicin, start having, especially for those population? So there are also multiple cost effectiveness studies studying the difference between fidaxomicin and vancomycin. We can see here that the Clostridium difficile related readmission is 20% in fidaxomicin group in comparison with the 41% in the vancomycin group. And see that the yellow culmin is the price for the vancomycin, and the blue one is the price for fidaxomicin. So fidaxomicin treatment was associated with a potential cost saving of almost $1,042. So probably fidaxomicin is saving money, is not more expensive than vancomycin, but we have to do our own cost effectiveness trials. And there are multiple other studies done in UK. They started to incorporate fidaxomicin. So as a conclusion for this part, I truly think that we have to start thinking about fidaxomicin, especially in those populations, because vancomycin significantly affect their microbiome. And now there's Derek et al. They are doing a randomized control trial in allogenic bone marrow transplant, comparing the short course of vancomycin 5 days with fidaxomicin also 5 days even. They are thinking that the shorter is better. Now, who is with, another question, who is with secondary prophylaxis with vancomycin? No one. Primary prophylaxis with fidaxomicin? Okay, so there are multiple trials in immunocompetent. Also, there was contradicting data about the efficacy of oral vancomycin as a secondary prophylaxis. However, no good studies in allogenic bone marrow transplantation. Surprisingly, there is a 2 randomized control trial about using fidaxomicin in allogenic bone marrow transplant, randomized control trial. And the last one was published just now in May 2024. The recent one suggesting that there is potential benefit of giving fidaxomicin as a primary prophylaxis when giving antibiotic. However, this study, the previous study in 2021, I guess, it showed that because they studied the gene sequencing for the bacteria or for the Clostridium difficile, And it showed that the bacteria developed, or the Clostridium difficile developed resistant to fidaxomicin. So until now, I think we should be very cautious in using antibiotic, and the best approach is to discontinue unnecessary antibiotics. And there is ongoing DEFLECT-1 randomized control trial as a primary prophylaxis in allogenic bone marrow transplant on 600 patients on fidaxomicin. Now, the other question, who will suggest fecal microbial transplant in allogenic bone marrow transplant? Also show hands. Yes? No? No? No. Okay. طيب طبعا it's still very contradicting. So fecal microbial transplant has been started in 1950s. However, they started treatment for Clostridium difficile in 2013. And recently on the pipeline, there is the Rebiota, which has been approved in 2022 as enema for fecal transplant in immunocompetent. Until now, there is no approval in immunocompromised. And there is the VOWST medication now. It's like a capsule approved in 2023 as also as a fecal transplant in immunocompetent patient. Now the question, is it safe to go for fecal microbial transplant? And what is the benefit of going for fecal microbial transplant? Actually, some studies are suggesting that if those population, those population are at very high risk for resistant organisms, and some studies suggesting that fecal microbial transplant may be the resolution of resistant organisms. So a lot of them colonized with CRE, VRE, etc. So probably fecal microbial transplant will change the whole flora and get rid of the resistant. What about the graft versus host disease? Also, minimal trials. I was surprised that there is trials done, retrospective studies about fecal microbial transplant in allogenic bone marrow transplant, and it was showing a protective effect against the graft versus host disease, because one of the theories of graft versus host disease is viruses and bacterial infection, which might trigger the immunity and induce the risk of graft versus host disease. So now the most important question, is it effective? We need more studies. Probably it is effective, but is it safe to go for a fecal microbial transplant in allogenic bone marrow transplant? There's only one randomized control trial also published recently in 2024. And it showed that it was only on 74 patients. It showed that it might increase the risk of graft versus host disease. However, the recent systematic review done on almost 10 retrospective trials on allogenic bone marrow transplant is showing promising results and safe results to go for a fecal transplant. Not only this, it reduces the risk of graft versus host disease. However, some studies highlighted that those patients might have bacteremia because, it is a fecal transplant, and they might develop bacteremia because they have a very weak intestinal or the mucositis. So they assessed those, the Chauval et al. Assessed 2 patients who developed bacteremia, and they took the PCR, studied it metagenomically, and sent it for a PCR. And apparently the sequencing showed that it was not related to the fecal transplant, it was related to hospital-acquired pneumonia. And recently, based on this systematic review and multiple retrospective study, the American Gastroenterology Association also in 2024 just published that immunocompetent patients, they have to go for a fecal transplant in a recurrent C. diff, and mildly to moderately immunocompromised can go for a conventional fecal microbial transplant. But we have still to avoid it in a severely immunocompromised group. And there is now undergoing a trial on randomized controlled trial about fecal microbial transplant on 150 patients. It will be completed, inshallah, in 2027. So until now, the conclusion for this part, until now, we don't know if it is safe to go for a fecal microbial transplant, but it is really worth studying it and trying it in allogenic bone marrow transplant who are at significant high risk for Clostridium difficile infection and other resistant bacteria. Is there any other medication on the pipeline? We know that there is the bislotoxumab as a monoclonal antibody, which will modulate the toxin itself,
2 minutes.
but no studies in immuno compromise. Now, the last thing for the probiotic. Probiotic is having a higher risk than the fecal microbial transplant because fecal microbial transplant, they screening it for the viruses and for the bacteria, but probiotic is very risky to be given to fecal microbial transplant. Bacteriophages has been studied in mice and it showed failing result in Clostridium difficile, and now they are trying the cocktail phage therapy in vitro. As a conclusion for this part, so Clostridium difficile infection has significant effect in allogenic bone marrow transplant. I think we have to start incorporating fidaxomicin in our hospitals, especially for allogenic bone marrow transplantation. And fecal microbial transplant hold a promising result. However, we need more and better trials in this regard. Thank you so much.